is just a huge honor for me today to bring to the show Chris Mark Bingham, DDS, MS. Received his Bachelor of Science degree from Brigham Young University in '98. He completed his Doctorate of Dental Surgery from the University of Illinois in 2005, followed by the completion of a General Practice Residency at the Rush University Medical Center in 2006. Is that what Rush Street's named after?
No.
Oh, different Rush? Okay.
Yep.
He then practiced as a general dentist for 2 years before entering Georgia Health Science University, formerly the Medical College of Georgia in Augusta, where he earned a certificate in periodontics and a master's of science in oral biology. He's a brainiac. He is the recipient of numerous awards, including the Richard J. Lazara Implant Fellowship. Now, is he related to Gaspar Lazar, who started Orthodontic Centers of America?
Maybe. Might be related. I think that this guy was he developed 3 eye implants.
I wonder if that's related to Gaspar, because Gaspar's down in Georgia. Anyway, Richard J. Lazara Implant Fellowship and a Strawman Educational Grant for his expertise and excellence in implant dentistry. Dr. Bingham recently achieved board certification in periodontics. Congratulations on that, man. That is awesome. He is and now a diplomat of the American Board of Periodontology. He is a member of American Academy of Periodontology, Academy of Osseointegration, American Dental Association, Texas Dental Association, and the Capital Area Dental Society. He's married to Penny, because Nickel and Diamond Quarter wouldn't even go out with him. And they have 6 children. With a strong focus on delivering minimally invasive, exemplary care, Dr. Bingham offers patients the latest in state-of-the-art periodontics and implant surgery techniques. He is trained and certified to perform the LANAP laser protocol for gum disease treatment and has extensive experience in a range of periolaser techniques. His use of advanced technologies such as periosurgery for enhancing safety and precision with bone grafting techniques and 3D CBCT imaging for advanced diagnostics underscores his commitment to incorporating protocols that improve comfort and treatment results for each patient who walks through their door. Dr. Bingham has a stellar reputation among his peers and patients alike and is a trusted periodontist for so many in the community to turn to life-changing periodontal and implant care. My gosh, thank you so much for accepting my invitation to come on the show. It's really an honor to have you on the program. I remember there was a periodontist out here, Alan Honigman, and I tell you what, I practiced this. I graduated in '87, and it was about a decade or 2 ago. I don't know how long ago. I think that's the first thing to go when you start getting dementia is time period. A lot of times I'll say, yeah, that was like 3 years ago. My kids say, Dad, that was 10 years ago or 15 years ago. And I'm always like saying 2 or 3. But anyway, Honigman was just an unbelievable periodontist. He bought this LANAP. I heard a dozen people talk behind his back, like, what the hell is he thinking? That guy's so smart. What was he doing? And everybody, all the periodontists and orals, everybody was bad-mouthing him behind his back. And then one by one, they would get the LANAP. And so I'm always telling Alan, I said, my God, talk about a legend, man. Everybody said you were crazy, and now time proved that you were right. But the reason I got you on the show is because I got the data on Dental Town. There's 250,000 dentists on there, and most of them just read the today's active topics like it's the news. But whenever you're going to buy something that's $100,000, like a CBCT, a CAD CAM, a LANAP, a Millennium Laser, whatever, they'll do a search for it, and then they'll read everything for like 3 hours. And so my homies get focused when it's a 6-figure purchase. And my gosh, you got so many toys. You got the LANAP, you got the Yomi robotic system. I mean, did you just not have any toys when you were a child? Is this what this all comes down to?
No, it doesn't. I did have toys.
Your sandbox wasn't empty, and you said someday I'm going to have a pail and shovel of my own. But my gosh, and you didn't say what type of 3D CBCT you have, but guessing you're a periodontist, I'm betting it's iTero.
No, I have an Icat.
An Icat. Interesting. Why do you think so many specialists have iTero? Oh, no, I meant Icat. iTero is if you're going to do clear aligners because it's owned by Align Technology, which owns Invisalign. So, yeah, all the orthodontists go with iTero because of Invisalign, and all the periodontists go with the Icat. I have the Kodak CareStream, if it matters, but why do you think yourself, with a doctorate and a master's degree, why did you go with the Icat like so many periodontists?
Well, I mean, I wish I could say I was following everybody else, but when I was looking at getting the robot, the field of view, I had another cone beam I had a great machine. It was a Planmeca. That cone beam field of view was too small for what was needed for the robot. So I had to get a Icat so that the field of view would be compatible with using the robot.
And is that owned by Stan Bergman of Shine? Is that a Shine product?
I don't know. I don't know.
I wonder. It seems like it is. I don't know. I mean, Stan's bought like 360 companies in his tenure, and a lot of them you don't even find out he bought them till the funeral, and you find out that 10 years ago, when he was doing his family planning, he cashed out, but they didn't want to say anything. It was a family matter, family business, or whatever. But he is the biggest mover and shaker in all of dentistry. Please tell me, with that new dental robotics, show me that it won't be long and I won't have to go to work. I'll just stay home in the jacuzzi all day, and my robots will go there and place the implants. And do I even need to get dressed?
Oh, you do, because it's really just it's a robotic guidance system. So it's not autonomous. It's not driving itself. So you have to virtually plan the case in software, and then you have to fix the patient to the robot, and then you have to get the arm of the robot in the position that you want it to go, and then you say guided, and then it'll lock in place where you want to perform the osteotomy, both buccolingually and mesial distally, and it also has a depth gauge as well. So what it's really about is robotic guidance. So as the patient turns, the robot will adjust the guidance system to follow the path of the patient. But really, it's about delivering precision and not having and still controlling it. Because, in talking with the folks at Yomi, they said that by cutting or by making it autonomous, most surgeons don't feel really comfortable just turning something over to the robot. They still want to be in control. So if for some reason in the middle of an osteotomy I need to stop, I step my foot off the gas and I don't have to push a button and wait for things. I still am the one that's pushing the arm of the robot with the drill into the patient, and I'm also the one causing the drill to spin. So I still play an integral role just as the robot does, but it's the collaboration of the two parts, me and the robot, that make for delivery of precision implant placement.
Well, we have a lot of kids watching the show. A quarter of our viewers are still stuck and trapped in dental kindergarten school. And I just want to bring a little history back before I start asking you these implant questions, because to me, of the 12 specialties, yours, periodontist, has changed more than any of them. When just put this in perspective, when I was in school, I got out in 87, and that first 10 years, man, molars with a furcation, we'd turn it into 2 bicuspids to clean. We would do root amputate. We'd do everything we could to save a tooth. And then it was about 95, and everybody said, the best periodontal surgery? Extract that tooth, throw it away, and place an implant. That was the miracle cure-all. And it took about 10 years before everyone realized, well, it's actually not really a cure. You're still stuck back at the same problem. And now it seems like in my world, again, 34 years later, that it's kind of really reverting back to the way it was, where now your periodontist is trying to save it. And he's like, let's do scaling and root plane. Let's do 3-month recall. And you're like, dude, 10 years ago, you would have pulled the tooth and FedExed it back to me. I mean, do you see that trend? Is that the way you see it too, or not really?
I mean, I do. I have to tell you that I'm not the first periodontist in my family. So my dad is a retired periodontist. And so as I was going through my training and hearing about what perio was like when he came out, it was osseous pocket reduction surgery and free gingival grafts. That's what he did when he was trained. And so then incorporated bone grafting, regeneration, and then he had to learn connective tissue grafts, and then donor grafts, and then sinus lifts, and then all the things associated with implant placement. And just to your point, we used to think that we put implants in to save the bone, and we've come to realize that implants don't do a good job saving bone. It's, we still have to be respectful of biology, and we have to, be deliberate, and we have to be intentional, and we have to understand the parameters under which implants can be placed successfully, and when teeth can be saved successfully. I mean, it's interesting. Occasionally I'll get a case from a general dentist. I had a patient here a week or so ago, and she was, I think, 35 or so. And when I looked at her X-ray, it looked as if the root had never formed. The pulp chamber was really wide. I think the cone that would fit it would be like 100. And he said, "We'll take it out and put an implant in." Well, talking with the endodontist, said, "Well, I think we really have got to see if we can save the tooth, because at the end of the day, if I took the tooth out, looking at the 3D image, the image was not going to, or the buccolingual dimension was not going to be favorable to implant placement. So even if we get a few years out of this, I think that it's going to be a much better outcome." And so it is, back to, I don't mean to digress, but it really is about when is it a good time to take a tooth out and when is it a good time to keep a tooth. And, taking teeth out, we used to think that, well, you cure periodontal disease, but we don't necessarily address the etiology of it by taking it out. So it is a delicate balance. And, that's one of the things that I love about perio is that I'm trying to, factor in patient factors, trying to factor in, health history. I'm trying to factor in a whole host of things in order to deliver recommendations that are going to be the best for the patient.
Now, if your dad was a periodontist and you were a periodontist, do you think it was wise to have 6 kids? I mean, it could be a genetic disease. And
well, it could be. It could be. And I would be okay with that. I mean, and Howard, just so you know, my brother's a general dentist. My cousin's a general dentist. My grandfather was a general dentist. I have an aunt and a cousin that are hygienists. So the joke in our family was we just didn't know that there was other ways to make a living other than dentistry.
That is hilarious. I'm going to be all over the map because I'm trying to find an expert like yourself to come in and ask a lot of these questions. The kids in dental kindergarten school, they're very confused because they're taught these are all the cases that you don't want to place an implant, like a smoker or someone overweight or a drinker, blah, blah, blah. Well, the people that lose all their teeth and have gum disease, it's not your yoga instructor. She didn't choke on a piece of kale. I mean, they're usually the drinking, smoking, crazy ones. And so it's kind of, they're confused because they're formally taught you don't do it this case. And then those are pretty much all the people that come in, It's like when an all-in-4 patient comes back. I mean, you always schedule them during your lunch hour because they're going to have an entire ham sandwich underneath the all-in-4.
Right.
I mean, you don't need to bring a lunch. It's going to be all there. I mean, why did they need it all on 4? Because they never brushed and flossed their teeth.
That's right.
And they should have had a removable that they could pop out and clean, but, they want it, fixed or whatever. So the question I'm going to ask you is... treatment planning. What do you do when a smoking, drinking, we'll assume he's Irish, a drinking, smoking Irishman comes in and she's like, well, I'm not supposed to do that on you. I mean, how do you balance giving people what they want, even though it's a high risk case and you'd recommend like an all-on-4, they should all be removals. There should be no fixed all-on-4s. It just shouldn't be, but that's, what would you say? 99% of them are fixed?
Yep.
Yeah. So 99% are misdiagnosed and mistreatment planned. So how do you balance that?
Like the in pros, and talking to my pros colleagues, they often say, I like to have a way out somewhere. And oftentimes when you go in all-on-4, there is no way out, is that you've now taken teeth and you've now ground the bone down. And when things start failing, they don't have a backup. And so when we're able to incorporate removable with all-on-4s, it certainly, and it means that we get to retain some bone and aesthetics are easier sometimes to manage with the removable appliance. And, so to answer your question, it's really a patient-specific thing. It might be, and in your scenario, Howard, was that patient, did they still have teeth? Were they completely edentulous? I mean, it's difficult to sometimes just in the context of smoking and drinking, if that is that in and of itself, the parameters under which we make the decision. But sometimes it's like, well, I haven't been to the dentist in a decade and now I want teeth. And maybe in those patients, that we got to get them to that place where we feel comfortable with it. And if they only have 6 teeth left, maybe we try to see, can they test drive keeping 6 teeth for a period of time before we talk about taking their teeth out.
And again, these are going to sound all over the board, but there's a poll on Dental Town. People are just saying, do you really need to record full mouth probings on your adult patients once a year? And 147 dentists have voted today on it, and 57% said yes, you have to take full mouth probings on your adult patients once a year, and 43% say no, only for selected patients. You would know. How would you vote on that poll?
I would vote that it do it every year.
And there's been a lot of technologies trying to get rid of that probing. What was the Florida probe, right? That's the one I'm thinking of. In my office, whenever the hygienist wants to probe full mouth probing, she's gonna get an assistant. She's gonna get someone to help record. So everybody, having labor be the number one cost in dentistry, everybody's trying to get rid of that, and the assistant that has to come in. So does Florida probe, is that a good thing? I mean, does that work? Did it get rid of someone else?
I don't know that the Florida probe is the answer, because it still doesn't often interface with all of the dental software. So it records it in its own proprietary software, and you'd have to have a parallel documenting system. So I don't know that necessarily that the Florida probe would be the answer. I do know that Dentrix had a voice operated system for a while that would integrate with their periodontal charting, but last I spoke to them, which was just a couple of months ago, that had been discontinued and they had some struggles with it. So I think it's still the old standby of probing, unfortunately.
Okay, this is the one. This is a question for my homies that just got out of school. In the last 5 years, they go work for a big DSO, and they see an insurance billing card for like a Reston, and their periodontist friend doesn't believe in this and doesn't do that minocycline or Reston or whatever, but the insurance code has one. And then the office manager of this chain is saying that, if they have a pocket greater than 6, you got to stick an Reston in there because there's an insurance code, and then they get money. First of all, so I know that's a lot of questions, but do you put a Reston in a lot of periodontal pockets, and is that a big part of your armamentarium?
No, it's a very, very small part of my armamentarium. I rarely use a Reston. At the end of the day, we like shallow pockets, and a Reston may do it for maybe non-surgical patients that you've already done surgery on. You may want to consider it, but for most folks, you got to address the anatomy of the periodontal situation, and we know scaling and root planing handles the inflammatory component, but it doesn't necessarily handle the anatomical issues that have come from bone resorption. So you really have to go into the cause of it, which would be either a regenerative procedure or bony contour osseous pocket reduction surgery. So it really is, at the end of the day, these DSOs may have an agenda to get more money in the office, and I would say that let's look at the cause. Let's address the issue. Let's make that 6 millimeter long term a 4 millimeter or a 3 millimeter. In many instances, that can be easily achieved by classical means.
Terminology is weird, and it triggers people. And one of the biggest frustrations I've had for, since 1987 is, well, why do I need a deep cleaning? Why can't I have a regular cleaning? And so I always thought maybe deep cleaning isn't the word. And then they went to scaling and root planing. I don't know if anybody does that. And now the big term is active gum therapy. Have you heard that one?
I have.
And so I know you're in Texas, where English is you're still learning that English. I know this because four of my 6 grandchildren live in Beeville. Have you ever heard of Beeville?
That's down, where is that? Is that down here in Houston?
Yeah, it's about 3 hours from Houston, but it's by Corpus Christi. It's about a half hour to drive to Corpus and Redfish and all that stuff. But I mean, I don't know how to say this, but they don't talk right. Dad talks perfectly, and 4 out of 6 of his grandchildren does not. But, do you think deep cleaning? Well, put them in order: deep cleaning, scaling and root planing, active gum therapy. Which one do you think scares people the least?
I think probably active therapy probably scares people the least.
Yeah, and you think that's why that term is coming out?
I'm not entirely sure. I think that maybe active therapy was another way to let patients know that we're doing something other than just the cleaning. I think when you use the word cleaning, it's just like, oh, we're going in for an oil change. And really, at the end of the day, scaling and root planing, active therapy, there needs to be an assessment done at the end of that, a month to 6 weeks later. And evaluate, does there other therapy that needs to be done? So I think active therapy is a reasonable term as long as you have the proviso or the caveat that there might be further treatment needed after the active therapy.
Well, the Endodontist Association is trying to get rid of the term root canal and say endodontic therapy. And all I'd like to say is good luck with that. I don't think that's going to be a big deal. So I'm going to ask you. I mean, because these kids, they need. I notice when we have a new person on our team, and when they hear the hygienist explain something the same way, and I do, we all kind of explain everything the same way after a while. So the standard question, well, why do I need a deep cleaning? Why can't I just have a regular cleaning? Talk to me like I'm the normal patient in Texas. How do you explain that?
Well, I mean, many times patients will come to me having been referred, and so their general dentist has said, what you need is beyond what I feel comfortable addressing. And so patients have been somewhat prepped before they come to see me. And so oftentimes, I may have a patient like you describe in my maintenance population. I say, really, things have gotten worse and we have to do something here. Otherwise, we're going to lose more bone around your teeth. And I don't want you to lose any more bone because things then the disease will then put this tooth in jeopardy. And so we've got to go back to active therapy or scaling and root planing, whatever term you feel most comfortable with. But we need to go back to active therapy, which means we'll need to get you numb and we'll need to go down and clean below the gum line. And when we clean below the gum line, that allows the body to relax and heal. These bacteria that cause the problem live in deep holes. And I don't like deep holes because you can't brush there. We can't clean there very effectively. At 5 millimeters, which your problem is exceeding, we're only about 40 or 50% effective. And if I can't get all of that tooth clean, it's going to just be a persistent problem. And I don't like leaving hangnail. If I were a podiatrist, I wouldn't like leaving a hangnail or an abscess there. And the concern is that this tooth will get worse, and you'll end up potentially causing a bigger problem. And so I like to get problems before they get too big. And your situation requires some active intervention, which will be this non-surgical therapy. Now, at the end of this, we're going to evaluate you in a month. And we're going to measure things again and see, did we get the outcome? Did we reduce the probing depths? And when we reduce those probing depths, then we'll put you back in a maintenance population or a maintenance pool. If things are still deep, we may have to consider doing some surgical treatment. And we can talk about what that surgical treatment is in a month's time after your scaling and root planing. But we will just need to make sure that those deep probing depths are no longer. And if they are deep, then we'll just do some surgery in order to make it better.
I'm actually shocked listening to you talk because in all your pictures I see of you have a lot of Elton John-ish glasses.
Yeah.
And I thought you'd really be rocking some Elton John glasses today. And I'm just kind of let down that you're not. But I'll try to get over it. I want to ask you another thing. In dentistry, it takes time to tell if something's a fad or if it's really real. And this oral health, what do they call that? The oral health.
The oral systemic linkage?
Oral systemic linkage, yeah. And my gosh, so she's very confused because, I live here in between two dental schools, AT Still in Mesa and Midwestern, and they're all into this systemic health. And I get it. The whole body's connected. I totally get it. But then she goes home. She only became a dentist because her mom's a dentist and her mom's an idol and her mom got into implants or whatever. And she goes back and she sees these happy patients that can now, with their implants and crowns, go chew cheeseburgers at Whataburger. But she sees this perio around it, like 3 or 4 millimeters, and it's bleeding. And she tells the patient that, that they got peri-implantitis, but there's no pain. He can eat the bacon off of a cheeseburger. And, and the mom's like, it's okay. But then she's thinking all this is spilling into the body. And is it contributing to Alzheimer's and pancreatic, everything? And so again, it's the real world. This implant has peri-implantitis, but the patient doesn't have a problem, so they're not going to pull a asymptomatic tooth that eats cheeseburgers to replace it. And the mom's, she's my age. I'm 59, so I'd say a 59-year-old's at least 80% senile. So how does she balance this young idealism between the systemic health, peri-implantitis, and the reality is that Grandpa Frank over there, he ain't got a problem with this implant crown?
So I just want to ask a question. So is the question that these patients come in with bleeding and deep probing depths around implants, and then how do you balance the bleeding that's around those things with making sure that that it's getting taken care of, but and having everybody buy in? Is that the question?
Yeah, exactly. Because he doesn't have any pain or function problem, and she doesn't want to be supervised neglecting. Like they always say, your gums are about the square area of your hand. So, if a part of your body had an area size of your hand bleeding, that's not right. So she's trying to balance. I want to be a good doctor. He's under my care. I don't want him to get systemic and all this stuff. But the patient doesn't have a problem. So how do you, and then when she talks about systemic health, a lot of older dentists, I've been at restaurants hearing older dentists tell these younger kids, well, none of that's proven. It's all correlation. I mean, every morning I get up, the sun comes up. It's just a correlation. Me getting up didn't cause the sun to get up. And so the wording between correlation, cause, effect, and the fact that the patient doesn't have any problems, but there is this asymptomatic peri-implantitis, deep pocket bleeding, and everything she learned at AT Still is this is not good.
Yeah, and so I would answer the question this way in saying that gum disease, when it was around teeth, was often the same story too. It didn't hurt many times, but yet it was bleeding. And when we're evaluating implants, we don't like bleeding because they don't have the same sort of soft tissue around implants. And so it's, again, better to take care of some of these issues before they get big. And so how do you do that? How do you do that in patients that are not caring for themselves? At the end of the day, you've got to convince patients that they've got to do better than what they are, and maybe they need to be seen more frequently. I mean, you can't go ahead and think that you're going to change the issue of maintenance on your own. You have to have a patient buy-in. So you have to get the patients to be willing to do more than what they've done in the past, and you have to educate them. But at the same time, I mean, at the end of the day, is this person going to die because their mouth has got peri-implantitis? Is it going to be linked to Alzheimer's and all the diseases that we now that they now share with inflammation? I think that there's a really pragmatic approach, is that at the end of the day, if you're not going to figure out a way to get the patient to buy into all the things that may need to be done, then all the things that you want to do is irrelevant.
So when I look at your one of your emails that you no longer use anymore, he's not real old. He's got a Yahoo old account. He's not like an at AOL.com. Those guys got all kind. But it sounds like you're Canadian, or
I am.
Oh, so you're a Canadian.
I am.
Where were you born?
I was born in a small town in southern Alberta called McGrath. It's about 2 hours south of Calgary.
Oh, wow.
And so I grew up, the story was I was born in Canada. A few weeks after my birth, my parents moved to Chicago, where my dad went to dental school and then did perio practice for a couple years of perio, and then he started his practice in Calgary. And so I lived in Calgary between the ages of 8 and 19, and then went away for a long time and came back after general dentist and lived there for a couple years.
Well, I really respect the fact that you had the morality and integrity to leave Canada, because you can't be a dentist and watch hockey. I mean, that's just a sport. I mean, all they do is knock out all the teeth, and those Canadian dentists just keep watching it. This one's going to get you in trouble. We're in the middle of a pandemic. I don't know if you've seen the newspaper or not, but there's this virus going around, and some offices are telling the hygienists they can't use the ultrasonic, and they're not happy. I mean, sometimes you just need an ultrasonic to knock that stuff off, but he's saying it's making aerosols and just knock it off. And I just want to say this, Starbucks, they on their locations, you know that company's great. The founder's name was Howard Schultz. I mean, that's a dead giveaway. That if they're named Howard or they're bald, that's a dead giveaway. And he liked them at the corner so that smell would go down both sides of the street. And he really believed that a lot of people who weren't interested in Starbucks right at that moment got a whiff of that coffee and then changed their mind. And Cinnabon was the same thing. They only went in malls and airports. They use a specific cinnamon that's more aromatic. I mean, it's only grown in Indonesia, and just like Starbucks, they just got one particular bean. And Cinnabon, well, when you walk into a dental office, dude, they stink. They smell like somebody died of eugenol. I mean, so when people say does ultrasonics makes aerosol, well, something's making the air stink, and you smell it in the paper and the wallpaper, and the whole office stinks. But for you specifically, you're in Texas. Do you think that in the middle of a pandemic of a aromatic aerosol virus that ultrasonics should be taken off the table and only go to hand scaling, or not really?
I mean, in our office, we do ultrasonics in the middle of a pandemic. We have N95 masks, and we have face shields. At the end of the day, the aerosols that are made from a handpiece, I think, are smaller than what they are with an ultrasonic. And so I think the risks are greater for us dentists that use handpieces as part of our regular are part of our regular day. So, we are in Texas, and we've been able to use ultrasonics for some time, actually.
And just the guests always want me to get a COVID-19 update. The show's listened to around the world. He's in Austin, Texas. That's southern central United States, right next to Mexico. I'm over here, 2 states over in Arizona, and over here it totally feels like they got the vaccine. There's light at the end of the tunnel, and I think it's just kind of fading away. Everything's busy. Is that the way you feel in Austin, or are you worried that one of these variants is going to come back and reverse everything?
I don't. I mean, I was talking to my sister here a week ago. She lives in Portland, Oregon, and talking about her husband's commute, and said, well, right now the commute's 15 minutes, but when traffic gets back to normal, it's going to be, 30 minutes. And I said, what do you mean? What are you talking about? I mean, traffic for me has been pretty heavy for the last 3 or 4 or 5 or 6 months. So I'm not in the camp that I think that the new variant's going to cause some big problems for us.
So, are you in, that's where Dell is in Austin, right?
Yep.
So have you met Michael Dell's dad?
I have not.
He's an orthodontist.
Oh, I didn't know that.
Yeah, one of the first times I lectured in TDA, it was like back in the, I don't know, it was like 90, 91. But anyway, he's the coolest guy. He's selling the table. We were all laughing at that. The good son went to school and became, he was an orthodontist. The good son went and became like an ophthalmologist, and everybody was on track. And then Michael comes home after like 6 days of college with all of his stuff and says he quit because he met all of his teachers and they're all idiots. And can he start a business in his garage? And he said that him and his wife actually cried that night in bed. They didn't know what they were going to do with this horrible, crazy, lunatic son. So I want to ask you, this is kind of a complex question, but on Dentaltown, you remember, let me pull it up. It was in 1977. Let me pull up, I'll go AI. When Reader's Digest came out with an article, and it said, "Are dentists ripping you off?" And I know that just sounds really bad, and why am I bringing that up? Well, it was a serious article. I mean, Reader's Digest, everybody's grandma had this on their nightstand. It said, "How honest are dentists?" And basically, it was a Pulitzer Prize-winning journalist, William Eckenberg, and who got a Pulitzer Prize on the 3 Mile Island stuff. And he simply, I think it was very scientific. He got study models, an FMX, and a Pano, and he went to 30 different dentists and got 30 different treatment plans. And so then the government found out, and the NIDR said, oh, man, what's going on here? So they redid the study with 100, And they only had 2 treatment plans for the same. That was 2 guys who said nothing, you don't need anything. And treatment plans 3 through 100 were all different. And and then I have heard this my whole life where older patients will snap at me in the office and I say, well, you get a second opinion. She goes, look, I got 4 separate opinions before I got my knee replaced, and every one of them was different. I mean, if you want 9 different opinions, see 9 different people. None of you guys know what you're doing. Everybody has a different story, and it's true. I mean, I see it on Dental Town. Someone will put up pictures, and like a person will have like a chip, and I'm like, well, do nothing. What are they, a model, or smooth it off? The next guy's 10 veneers. The next guy's pull the teeth all on 4. I mean, they're all over the board. So when you're looking at and I can prove it with you in your profession the most. It seems like for every 25 dentists I know, 5 of them refer 100% of all the crown lengthening procedures to their periodontist, and the other 20 have never sent them one.
Yep.
I mean, do you have that? Is it the 80-20 rule with you, where 20% of your referrals are 100% of your crown lengthening?
Yeah, probably.
So are we doctors or are we palm readers? I mean, you would think that this was an exact, like math. I mean, sine, cosine, tangent in geometry doesn't care what your opinion is. It's
right.
Math. So how do you rationalize with the Reader's Digest, the NIDR, and even crown lengthening that there's no consistency in diagnosing and treatment planning?
I would agree with you, and I don't know what the remedy would be for that. I don't know.
I think it would involve cheese. I'm just hoping. I'm an optimist. I just think I can solve most of my problems with cheese. But so when some dentist is telling you and they speak like this is gospel, I don't even know what the gospel of dentistry would be. I mean, it seems like it's just all over the board.
I mean, it's crazy to me how many of my referrals, and I talked to them and they said, do you have any crown lengthening? I don't really need crown lengthening. I mean, I'll even talk to prosthodontists and says, no, I don't generally crown lengthen anything. I just, if it has a problem, then I'll send it over, but it's typically not on the front end. Do they consider doing that? So it's an interesting, dynamic where, I don't know.
Well,
I don't know what the answer is.
For the children, because for them it's tough. So you got married, you have 6 kids. I don't want to get too personal, but did you sign a prenup with your wife?
No, I didn't.
I know. So, you can tell dentists 100 times that, you're not going to buy a practice without getting a contract. But when they go back and work with mom and dad, it's just like getting married. There's no prenup with your wife. There's no prenup with dad. And then when it goes south, you're all like, I grew up on Judge Wapner. What was his first question? Did you bring your receipts? I didn't keep any receipts. And everybody, me and my 5 sisters are screaming, you idiot, how would you not keep your receipts? So, she's going back, she's working with her mom. So just on behalf of the children that got to get along with their mom and dad, their dads never referred a crown lengthening procedure, and she was formally taught this at AT Still and Midwestern. And so will you just explain, since it's the 80-20 rule and 80% don't do this procedure or have any need for it, I think it's worth you explaining what it is and why you do that.
So sometimes when dentists need to put a crown on a tooth or even a filling, the edge of the tooth or the edge of where the cavity or the crown is gets too close to the bone. And when it gets too close to the bone, the body doesn't like that and it can cause chronic inflammation. So if they put the edge of the crown below the gum too far, the body is going to be unhappy about it. And it creates gums that are going to be irritated and swollen. And so what crown lengthening is where the end of the bone is lowered and made further away from the edge of the crown. And when it's made away from the crown, then the body can relax and not be irritated by having the edge of the crown be too close to the bone. And so with crown lengthening, I just need to create a little space. It makes the restoration for the dentist much easier, and it's a win for everyone.
Again, I'm all over the board because I got every hour I thought about this podcast, I could write 5 more questions. Pediatric dentists are using silver diamine fluoride, and there's a lot of that going around. Some people are swearing by these iodine products from Iotech International, where it's products powered by molecular iodine. Well, everybody knows iodine, chloride, chlorine, iodine. Do you use that? I mean, are you using iodine?
I'm not, but I'd consider it.
Yeah. My gosh. What about, I'm in Arizona and I'm no financial connection, but up the street from me, from right where I'm at, is a company that sells a camera probe to go down underneath the gums so you can see when you're down there scaling. Do you use that?
Yes, we have that, and we were just trained on that about 2 weeks ago.
No, really?
Really?
Wow. My gosh. Unbelievable. And then, are there any of these oral health? I'll bring up one, and I know you're going to think this is for selfish reasons, but it's not. Oral health and erectile dysfunction from the NCBI, NIH. In light of the available research, evidence indicates positive link in CP and ED. It was also suggested that CP should be considered risk factors for ED. There's so many. I mean, on Dental Town, there's 100 threads about gum disease located with, these diseases, dementia, Alzheimer's, erectile dysfunction, all these things. Are there any of those things where you say, yeah, that's absolutely true, that's solid, that is a connection, and versus, no, I don't believe that?
Well, the way I would say it is that most diseases have an inflammatory component. And that's the link that periodontitis has with these, is that the common elements are the inflammatory pathway. And so, the link, if periodontal disease is linked with erectile dysfunction, there's probably some inflammation that's linking those two together. And so I don't think that it's a big stretch to start saying that all these diseases are connected, because inflammation is all over everywhere. I mean, when we start looking at inflammation, it's also in the diet that we have. I mean, it's everywhere. And so do we start talking to our patients about what they're eating? Do we address inflammation systemically by diet? If they're not sleeping well, there's also going to be a whole bunch of inflammation. I mean, another hot topic in dentistry right now is sleep apnea. And sleep apnea causes an increased inflammatory state as well. So, I think that as we're being more holistic about things, that we can get to have some conversations with our patients. Are they sleeping well? Are they eating right? Are they, doing all of these, are they taking care of their diabetes and all of this with respect, or, to take care of inflammation in their body?
So I want to go back. I feel like I should be spending all the time on this with Lenap and Yomi, because you're a little stud on these two subjects. But let's go back to let's go back to Lenap, or periimplantitis. I want to another confusing thing for the kids is they see people saying that this percent of implants have periimplantitis, and the range will be from like 20 to 80%. It's like, how can you have that wide of a number? I mean, no one would be off 80% on how far away is Venus. So I mean, is that 80%? Is that including a 4 millimeter pocket and bleeding? So if someone just asks you, if you place 100 implants in 5 years, how many of them would have gum disease that you call periimplantitis? True gum disease, not gingivitis.
I'd say probably about 30%.
30%.
Yeah.
And this Lenap, is that the sole reason you bought it, to treat periimplantitis, or is it also half and half with real teeth?
It's interesting that you bring up Lenap. I actually just got like my bio needs to be a little bit updated, because I'm in the process of no longer offering that. So I have a history of doing Lenap. And I think that there's probably a small place for it, but I think that other means are able to achieve similar outcomes.
And name one of those means. Was it a chemical lavage? Was it like iodine or?
Yeah, I think that those would have a similar outcome, because at the end of the day, a laser doesn't sterilize a pocket, and the bugs that are still causing a problem are still in the mouth, and we can't sterilize the mouth. If we were, then there'd be a different story. But just because we pass a laser or lavage stuff with chlorhexidine or whatever, I think that it still comes down to mechanical debridement and keeping it clean.
Well, you can sterilize the mouth. I've done it successfully many times. You just take the entire patient and cremate them,
Yeah,
and
there you go.
it's all
You're
gone.
right.
It's all gone. So, back to diagnosing treatment planning. I want to tell the kids something that there's 12 specialties out there, and I don't want you to become an A dentist. I want you to become an A diagnosis and treatment plan. I don't want you to get an A on a root canal, but an F on the diagnosis. The tooth didn't even need a root canal. I'd rather you just get the damn diagnosis and treatment plan correct, and then if you're a C dentist from there on out, I'll take that any day. Then, well, he didn't need
absolutely.
a bypass.
Absolutely.
And it's so important. And of these 12 specialties, the periodontists, I don't know what it is about them, but they're the masters of diagnosing and treatment planning. So what you need to do when you're a kid, this is what I think so dumb. No, I shouldn't say dumb, but I mean that's unnecessary. Is you live in Phoenix and you want to learn something about perio, and you always have to get on an airplane and fly across the country and drop $3,000 at Coy, Spear, Ross, Pankey. And you had to drive past 6 periodontists on the way to the damn airport.
Yeah.
I mean, you're insane. And all the specialists, they're all like the dentists. They're all introverts. They're all shies. They all lived in libraries. I mean, your wife probably reminds you of a librarian because that was the wildest, craziest woman in the library. But the bottom line is, you got 12 specialties recognized by the ADA: oral surgery, endo, perio, pediatric, ortho, pros, dental anesthesia, oral facial pain, oral med, oral path, oral radiology, dental public health. And what you kids do not know that you don't know nothing about diagnosing treatment plan. And when I set up, I could pack up my FMXs and charts and study models and call my periodontist and say, can I meet you after school, to go over this? And they all say yes, because they're just like that. And that's where you're going to learn all the education and diagnosing and treatment plan.
I mean, that's the thing that I love about being a periodontist, is the opportunity that I have to talk with some young dentists. Because sometimes they'll say, well, can you put an implant into 30? And I said, well, yeah, you bet I can put an implant at 30, but it's missing number 3. We got to figure out, well, if we're going to put an implant in 30, we got to at least figure out what we're going to do with 3. So there's an opposing tooth to it. And then, by the way, you got, a tooth on 4 that's got a failing restoration and probably needs some crown lengthening. I love those conversations. They're difficult to have, but I love them because we get to talk about, I hear a lot in dentistry that at least in some parts that, dentists need to be busy and there isn't enough to do, and we got to, start doing a lot of things. And I think that for many folks, I could go into their office and be in their hygiene and say, hey, look, what are you going to do about this or this or this or that or that? And there's a whole bunch of stuff that's there that if they just sort of thought things and looked globally and maybe slow down a little bit and really think about what they're all about with their patients, then they'd be able to do much more exciting dentistry and be able to take better care of their patients. I agree wholeheartedly on the diagnosis and treatment planning issue. I totally agree.
And go ahead.
I was going to say that I would welcome discussions with general dentists who need some help or want to even understand what it is that we see from a diagnosis treatment planning. I mean, one of the things that I loved in my specialty training was the interdisciplinary component of it. We'd be having seminars with pros, and we'd have seminars with endo, and we'd have seminars with ortho. And I think for me, periodontist is a nice integrator of all the disciplines, because we get to pull, really this would be an ortho case, and this one over here we would benefit from taking the teeth out. So, I mean, I love being involved in a whole bunch of different things. And I again, wholeheartedly agree with your comments about treatment planning and diagnosis.
And let's talk about the last thing you said about the dentists are trying to do everything. Okay, so in 1800 or 1900, there's no specialties in medicine or dentistry, and healthcare is 1% of GDP. A century later, 2000, healthcare is 14% of GDP. Dentists have 8 specialties, and medicine has 58. Now it's 2021, and we're up to 12. And I assure you that we're not going back in time. I love the enthusiasm when you come out of school and you're like, I want to learn to place implants and bone grafting and root canals and silverdimine fluoride and ortho and Invisalign and prosto, and I love it. But slow down, Spanky. That ain't how the world works. You got to get good at one thing. And then you say that that's not true. Well, hell, I know it's true. Look at In-N-Out Burger. In-N-Out Burger, there's almost nothing on the menu. It's a hamburger and it's some fries. Look at Chipotle. Chipotle was the genius thing where they went into the Mexican food restaurant, but your average Mexican food restaurant's like a 6-page menu, and they stripped it all down to one thing. My gosh, it's In-N-Out Burger, it's Chick-fil-A. Nobody is trying to master a half dozen different things except my homie does. I mean, look at In-N-Out Burger. It's a double-double, a cheeseburger, hamburger, and french fries. I know because I'm committed to obesity, and so I have to go there daily. My periodontist makes me. And yeah. I mean, if you're going to learn all 12 specialties, then why don't you call up In-N-Out and tell them how smart you are and that they should offer pizza? I mean, hell, why not just throw pizza on the menu? I mean, it just doesn't make sense. Get good at one thing. I actually recommend that you just specialize. So that was my next question to you. My gosh, there's 12 specialties. I know this is a weird time. I mean, we're in a pandemic. Things are crazy, and as bad as the pandemic was, that doesn't even bother me. It was, I graduated in 1980. That was the worst economy I'd ever seen. When Paul Volcker, the New York Fed, busted inflation, we had interest rates at 20.5%, inflation double digit, and then I graduated in May of '87. 133 days before Black Monday. That was really nice. And then Y2K, Lehman's Day. And I've seen this movie 4 times, and I'm in the middle of the movie right now, and I know how this movie's going to end. I mean, price earnings ratios on Tesla. If you would have bought Tesla at the fall of the Roman Empire, you still wouldn't have got your money back 1,500 years later with a PE of 1,500. So I feel that just as this pandemic was a right hook and broke half your right teeth out, and then it's going to be followed by the left uppercut. And because we have a cycle every 10 years, because Joseph Schumpeter, who got a Nobel Prize in economics from Austrian cycles, they said, well, why is there business cycles? And they says, because crazy people make all the decisions. And, and until you get rid of the crazy people, it's not going to go away. But I'm telling you, kids, I know it sounds counterintuitive, but just be In-N-Out Burger. What was it? Long John Silver's. No, it was Red Lobster invented the popcorn shrimp. They didn't add pizza and hamburgers and cheeseburgers because they want to be everything. In-N-Out Burger, their menu's got 7 things on it. Chick-fil-A, I mean, just get good at something. And I think the easiest way to get good at something is go specialize. But in asking you, for all you've been through in your periodontal specialty, I mean, going from save the tooth, throw away the teeth, shit, I don't know if we should keep it or throw it away, or 50-50. Do you think periodontist is still a good specialty, or would you say no?
I love being a periodontist. I think it's a great specialty. You talked earlier in the program today about how perio has changed a lot. It has changed a lot. We get to grow bone for a living. What professions get to grow bone for a living? What professions get to see tissue response? I think who can move gums the way that we get to move gums. I mean, I think it's a really awesome. I love what I do. I was a general dentist for 3 years before I became a periodontist. And part of why I did it was in response to thinking the way that you're describing is that I felt like I was drinking from a fire hose. How am I going to be good at endo? How am I going to be good at how am I going to be good at removable pros, and how am I going to be good at, taking teeth out and all of this? It was really overwhelming. And I think that your advice to young dentists is, if you are interested in surgery and want to be, involved in placing implants, by all means, but you got to dedicate significant time to do that. You dabble in everything, you're never going to be the master of any of them. And so I totally agree with what you're saying.
I'm sorry to revisit this previous question, but I got to ask it again because, again, insurance matters. You remember when the X-ray machine was invented by William Rehnquist. William Rehnquist? Dentistry had no interest in it until after World War II, and Roosevelt had passed a law that you couldn't raise any salaries during the war. So the longshoremen, where no boat got in and out of America without going through the Longshoremen Club, and they said, well, if we can't have any more money, well, then you got to give us something, give us free dental. And that was the birth of Delta Dental in Washington and Oregon and California. And when it came out, they covered an X-ray at 100%. And now all of a sudden, every dentist had to get an X-ray machine. It's like, no one thought about it before, but when old Delta Dental covered 100% of X-rays, it was a domino effect. And again, this medication after dental debridement, they're paying for this stuff. And so, person's asking, for patients who have generalized chronic periodontitis, do you always deliver medication into the periodontal pocket after scaling and root planing? What medication do you recommend? Is it minocycline, doxycycline?
I don't prescribe any. I don't prescribe any.
So, do you recommend they do this for the PPO, or do you think it's just that you don't do this, period?
I just don't do it. I don't do it because at the end of the day, if we got the junk off the teeth, the body will heal with will heal, and there's no scientific, there's limited scientific evidence that supports addition of minocycline. So the way that I've developed my practice is that there has to be a patient benefit to do something, and there is none. It just increases the cost for the patient, but the outcomes don't change.
Okay, well, that was actually the follow-up question to even that. You're probably going to hit me is, well, maybe if the minocycline, doxycycline is too expensive, should you just write a prescription for it, 250 milligrams 4 times a day for 10 days, or 250 milligrams twice a day for 10 days?
They've changed the periodontal classifications, but the only patients that typically will get scaling and root planing are maybe those that are uncontrolled diabetics, and it would just be amoxicillin. And if it's, what we used to call aggressive perio, they would get amoxicillin and metronidazole. But, 95% of the scaling and root planing I do in my office, we typically don't add any sort of antibiotics to the mix.
Another thing, money's the answer. What's the question? I tell everybody when they got an idea, hold up their hand. A full hand, where you're going to win every time, is your business is faster, easier, higher quality, lower in price, and smaller. And dentists always come up with an idea, and they're, oh, it's so good, it's so much better, it's so much everything. And I'm like, yeah, price, tell me about the price. Well, it's so good, it's twice as expensive, and only the kings and queens will be able to afford it. And I said, okay, you're just making some noise until someone with a full hand, faster, easier, higher quality, lower in price, smaller, is going to mow you over from behind. So when you're looking at keeping price cost, there's this saliva testing, and they want to be a good doctor. And when they go to their physician, he runs tests and sends blood and all that stuff. Are you doing a lot of saliva testing? Are you running a lot of lab tests? Or
I do select cases. I think it's probably the greatest benefit is a patient education tool. From the results that I've seen typically don't adjust my treatment recommendations. And so if I feel like patients may benefit from an education standpoint, then I would do it. But I typically don't make that a standard way of doing it because, again, for me, my patients have to benefit from the treatments that I'm recommending, and I have to be confident that doing testing it with all patients will benefit all patients, but I don't know that it does.
Okay, more weird questions. When I was little and I got out of school in 87, a big part of periodontal disease was splinting teeth with ribbon or orthodontic wires. I mean, my God, and that ribbon guy looks like Albert Einstein with all the white hair and all this stuff. And everybody was splitting teeth with either ribbon, which is some fiberglass deal, or an orthodontic wire. Is splitting? It seems like it's kind of going down. Do you do a lot of splitting anymore?
No, I don't. I don't. I don't. At the end of the day, your teeth that are all limping will then make teeth that are currently strong weaker because now they're taking the forces from the other. So, I typically don't do a lot of splinting. I do it occasionally, but not very often.
Yeah, and do you think it's kind of going away?
I do.
Yeah.
I mean, who likes going back and rebonding 15 times? That's sometimes the issues. I mean, everything is good, and then these teeth have grade 2 mobility, and your time together, and it might be time to consider other options.
I'm gonna ask you another question. Then you're just gonna know I'm either old, dumb, or stupid, or whatever. But same question for ANUG. It seems like when I got out of school, there was a lot of ANUG, and it just seems like it kind of went away. Am I just?
I don't see it very often either. I agree. I don't see it.
So why do you think a big disease like ANUG, which in the 80s, I mean, if you didn't have ANUG, you weren't even cool. I mean, you had to get what was the other one disease? The mono. It's like, God, it seems like so many people had mono and ANUG, and I just don't see the ANUG anymore.
Yeah, I don't. I don't know. I don't know why that is.
Yeah, you don't know why either, but you do see that too.
Yeah.
So what do you think as periodontal? I mean, would you say that you guys are half implant, half what do you call the non-implant perio? Just traditional perio?
Yeah.
Traditional. So would you say you're would you say you're half traditional, half titanium?
I'd probably say more traditional. I'd probably 60, 60 60% perio, 40% implants.
Okay. And with the implants, are you agnostic, or do you think some implants are just going to have a higher success rate? I mean, you're not going to believe this when I tell you this, but there are now 600 implant manufacturers registered at the Cologne and the IDF meeting, International Dental. No, not IDF. The IDS meeting in Cologne, Germany, every other year, and 400 of the 600 are just in Italy. Italy has 400, 400, and every one of them's owned by a periodontist like you, and they got a whole day's lecture of why theirs is the cat's meow and yours is just a dog bone. So how much of that is true? How much is this hype? How much do you think the brand of the implant has impacted the success of your treatment planning and success rate?
I mean, that's a good question. I think generally I'm probably fairly agnostic. I do have a preference on a couple, but I think that the fundamentals of osseointegration are not brand specific, and so they'll often tout bone implant contact, and one will have more bone implant contact, but the difference between them may be marginal, and it may not even be clinically relevant.
So it's Dentistry Uncensored. You got to mention those brands. You said your brand, a couple of them you like. So I know all my homies just said, well, which ones are they?
I really like Straumann a lot. I think that Straumann has a lot of different options available. I mean, they were the early ones in tissue level, and there are times that I'll use a tissue level implant. If it saves the patient from a sinus lift and we get a 6 millimeter implant in, then I'll do a short implant. And then it also they have tapered implants, and then they have a new one, BLX, which is a aggressive thread for immediate implants. So, I mean, I like Straumann, and I know that it's a premium one. I pay more for it, and sometimes brands make a difference and sometimes they don't, but I've had good success with Straumann.
Well, I bet Thomas Straumann loves you. Does he send you a Christmas greeting card?
No, he doesn't.
Oh my gosh. Yeah, and I'm a dentist and I got an MBA, and what I loved about Thomas Straumann, is his M&A activity. I mean, he's bought Neodent. He's bought the biggest implant in Brazil. He bought one in Israel. Do you remember which one that was? Was it MIS? Make it simple, or
No, I don't know that it was MIS.
it
I'm
wasn't
not sure
MIS.
which one.
But he's my gosh, he's just been buying and selling and buying and selling, and the biggest periodontist I know of, same way. I can name 4 periodontists to this, and I can name 100 dentists where, every time an older periodontist within 5 miles of the office went to retire, this guy he'd buy out his practice, because he's like, well, I don't want some young, energetic young kid who's still in his 20s that's going to be in the family fair and the schools and all that stuff. He goes, hell, he's an old man. Every time they sell their practice, they always run out of money because,
Yep.
you decide you want a new truck out of nowhere. And so they just buy him out. And then that man says, well, I'm just going to work here 2 days a week for a year. He's still there 6 years later till he dies. Okay. And same thing with general dentist, man. I mean, I know guys who, when they got out of school, went to a small town of 10,000. And usually in small rural America, you have a dentist for every 1,000 because the draw is twice the city. So America has a dentist for every 2,000 people. So in a town of 1,000, there's another 1,000 draws, so it'd be 1 dentist. So if there was 10,000 in that city, there'd be 10 dentists, because the draw is another 10,000, 20,000. I know several people that they go in that town and there were 10 dentists and they were 25. And every 5 years, the oldest guy retired and they just buy that practice. Now it's 30 years later. He started that town with 10 dentists. Now the town has 4 buildings, and 6 of those dentists working there. And you know who that reminds me of? Did you ever read the book of The Founder of IBM by Thomas Watson Jr.?
No, I didn't.
This is how simple business is. He noticed that when he was a little kid, back in the 50s, you had to go to the hardware store a lot. Your cars were made by Chrysler. You always needed a screwdriver, a hammer, a nail, or whatever. And he noticed that it really stuck with him that his small town had 3 hardware stores, but one of the hardware stores had 2 people, and the other 2 each had 1. And he noticed that the one that had 2 people had half the market, and the 2 that had 1 had they each had a quarter. And so when he inherited IBM from his father, he just thought, my gosh, if we want to get 70% market share of the computer industry, then 70% of all the computer salesmen should work with IBM. And all he focused on was an IBM training center where they all had to have the same navy blue suit and the same briefcase, and they would go over the sales call and all the like, if you say a patient, you need dentistry, they're going to say, will it hurt? How much? Will insurance pay? Can I go back to work? There's only like 6 or 7 questions they ever ask. And he just focused on every 6 weeks, they graduated another class of IBM salesmen, whether the economy was booming, going down. He just knew it came down to market share. And I don't know why all of these 40, 50-year-old dentists just sit there on their hands while some 65-year-old half-blind dentist sells his practice and retires, and you let him sell it to a 25-year-old, and you're already 40. I mean, go to boxing. How many heavyweight champions make a return to the ring at 40 or 50? I mean, you're too old for that stuff. That's why I tell kids when they get out of school, the best time to start a practice and start a family is the day you graduate, because by the time you figure out what you got yourself into, it's too late, you're done, and you made it. But if you sit there and start thinking, I made 4 boys in 60 months. I was so proud of myself. And my gosh, because by the time you realize all the risk you took, open up a dental office, and 4 kids, I mean, for a decade, there was a baby in my bed I don't care if you put them down to bed at the bottom of the ocean and the bottom of the Grand Canyon. When you woke up, they were in your bed. I mean, you could tie them up in the closet, wake up, they're in your bed. And so you need to do that when you're young and dumb and haven't thought it out and have all the energy. Just start your family. And if you're like, well, do you think we should have 2 kids or 3 kids? Well, 3 kids is better than 2, because that 3rd one, it should be a human too. I mean, you don't want to pass on a human to get a dog or a cat or a goldfish, and you don't want to wait till you're old and tired to quit your comfortable associate's job at a DSO where they pay you just enough to kill off all your dreams. And my gosh, I'll tell you what, on Easter, two of my boys have grandbabies here, and I got to see both of them on Easter, and I just look at that, and I mean, there's only one kid, and I'm just like, how did I do that? I could never do that again. Because at 59, you're like, I could never have that much energy. But Zach's, what is he, 24, and Ryan's 26. They don't even know how much energy they have. And that's why you should start a dental office the minute you graduate. Because when you come out of school, you tell me that you're going to go get a DSO because you just need to save some money and blah. If you've been out 5 years, you've worked for 5 DSOs. You've been out 7 years, you work for 7. You're never happy. You're miserable. And the only reason you open up your own office is because you're finally so miserable that now you're no longer afraid of going under. You just hate your life so much that you're finally going to start your own practice. I remember one time I took this woman to dinner, and she cried for an entire hour, and she just got so mad she started her own company because she just thought every single person she works for is an idiot. And it's like, yeah. And it's the same with kids, man. Just whatever number of kids you have, just have them before you realize what you just did, okay? And then it's too late. Now you own your own practice. You have a family. It's all good. But dentists, they overthink too much of this stuff. It's just way overthinking it. But I want to just finish on implants. When I look at macroeconomics, I really, this thing started with Pierre Fauchard 200 years ago. He's a barber surgeon. He was the first one that said, let's give up the barber stuff and just do dentistry. He wrote a textbook, and there was dentistry. I remember one of the oldest dentists I ever got the honor to practice was George Rui in St. Joe, Missouri, and he was 92 years old. And I asked him, I said, well, when did you graduate from dental school? And he said, 1927. And you don't have to be a genius to realize that 2 years later, I said, oh my God, you graduated 2 years for the Great Depression? Was that the worst thing that ever happened to you in your life? And he goes, that was the best thing that ever happened to dentistry. And I said, what are you talking about? And he said, we were all outside and we couldn't afford to go inside. And then the Depression came and everything went bankrupt. They were all boarded up, and then the bank's holding the mortgage, and they were boarded up. And finally, they just started coming around the street and says, this building's vacant. Do you want to move inside? And he said in 32 to 36, all the dentists, when they moved inside, they gave up the barber stuff. That's what Pierre Fauchard was trying to do. Everyone was a barber surgeon. And he said, no, He made dentistry a specialty of medicine. That's why when you periodontists say that you're a specialty, no, you're not a specialty. Dentistry is a subspecialty of medicine, and perio is a subspecialty of dentistry. And he was trying to get dentistry as a specialty. And he says, you can't cut hair and shine boots and be a damn doctor. You got to quit this stuff up. And it was 100 years later after G.V. Black that it came to America during the Great Depression. And George Rui said that when everybody went inside, they just quit cutting hair, they quit shining boots, and that's when dentistry really became a profession, is when they moved inside. And then I said, what about Prohibition? And he said, yeah, everybody understood dentistry, and we bought our alcohol in medicine bottles, and the sheriff would always look the other way, and we'd administer it. What we did is we administer tablespoon after tablespoon after tablespoon of whiskey until they vomited, and the minute they vomited, we'd reach in and pull the tooth. And the sheriff knew that if he was sitting in that chair, he'd want that medicine too. So he said alcohol was never, ever enforced. He knew Missouri, Kansas, Iowa, and Nebraska did not enforce alcohol from the dentists in Prohibition. But in saying all that rant, when I got my MBA in 98, and when you look at dentistry, it's a very old profession. So it just grows about maybe 1.5% faster than the rest of the economy. It acts like a luxury item. Obviously, as you get richer and richer, you want to keep your teeth and not lose them. But the only two areas growing double digit is implants and clear aligners. And so a lot of kids are coming out of school and they're thinking, well, my God, all the growth. Or another way, look at demand. What are your patients asking you about? They're always asking about Invisalign and can I have, those fake teeth stuck back in my jaw? So if a kid, you're not an Invisalign expert, I assume, but if a kid was wanting to pick the double-digit growth implantology and he was going to be an implantologist, what would you advise him? Would you advise him I mean, to go back to school and be a periodontist, or what would you tell the kid if he wanted to start learning how to place implants?
I mean, I think get as much education as you can. Whether it be, a multi-week program. I mean, I know there's some programs that they meet once a month for a year, and then I think that you just have to do it a lot. I think that being a specialist allows you to see things that you may not, and be able to tolerate different challenges that come when you're learning a new area in dentistry. I think that. So I think to answer your question, I think being a specialist would be a good way to do it. Although some would say, well, I can just go and become a guy who does implants without being a specialist. And the answer is yes, you can. But it just takes dedication. And are you going to be disciplined enough to dedicate yourself to learn? Because you're going to be held to the same standard as specialists are in any of the procedures that you do.
I hope not to get you in trouble with this question, but it might not be pretty. But there's a pinhole technique, and a guy was patenting it. I mean, this is my technique. Other people are saying that wasn't patentable. That's not your technique. Blah 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 blah. Do you do the pinhole technique? Is it something that you think should have the intellectual property of a patent, or do you think not really?
To be clear, I haven't taken the pinhole technique, but soft tissue grafting, utilizing what I understand the pinhole technique is, we've been doing that for many years. And so it's essentially a vestibular incision in that you're elevating the soft tissue up and off the bone. And then I think that he places membranes or collagen down into the tissue. I think that we've been doing things similar to that for many years. And so I have a hard time appreciating the why that is patentable. So I don't know.
There's a lot of marketing. I mean, Americans spend $30 billion a year just on all this floss and toothpaste and all this stuff. And a lot of them are making claims about gum disease. First, we have the New York Times that says there's no evidence about floss. Thank you, New York Times. That's what I needed on Monday morning. Thanks a hell of a lot for that. What was your next best story? And then you got mouthwashes that say use mouthwash. You don't even have to floss. And then they ask you, well, this mouthwash is for whitening my teeth. This one's from gum disease, and it's big money. I mean, they're putting this message in front of them all day long. So, what is a young dentist who's not a periodontist with a board certified and a master's degree? Do these mouthwashes for gum disease? Is that a thing? And is the New York Times right? We don't have to floss. There's no proof of that. How do you talk to patients about oral home care, brushes, flosses, and mouthwashes?
I mean, so at the end of the day, it's about disrupting the plaque or the biofilm, right? So it's about mechanical interactions with the tooth. Brushing, flossing. Sorry, Wall Street Journal, I think you got it wrong. As far as mouthwash goes, it doesn't disrupt the biofilm. It is not mechanical. Water picks are good if you need to blast big, if you have spaces between your teeth and food catches there, but it does not replace flossing. And for folks that have big space, open embrasures, we'll have them get a smaller brush, a proxy brush to do that. As far as mouthwash goes, I don't necessarily recommend any mouthwash. I say if you like the taste of it, that's fine. But I'd avoid alcohol-based mouthwashes and use that if you like it. But I don't typically encourage my patients to have a specific mouthwash.
Okay, here's another one. Arguing with her dad, and this is stressful because I know her and I love her and her dad. Every time the dad sees an abfraction, he fills it in with composite. The daughter doesn't even think that we even know what caused that fraction. I mean, if you go historically, they said it was toothbrush abrasion, and it was actually veterinarian dentists who said that's funny because all the antelope have them and they don't brush their teeth. So then it got to be the tooth is flexing and popping off. But anyway, long story short, you see these abfractions. I don't think you could get two dentists to agree on what causes them, and you're not going to find anybody to agree on what treats them. Some people want a skin graft over it. So It's an asymptomatic abfraction, and they got them on 6 teeth, the upper canines and premolars. What do you do with that?
I mean, the answer, I would say that it depends on what the patient wants. If the patient wants me to cover it, fix it, I can. But I like to listen to see what the patient wants. Says, well, I don't like how this looks, and said, well, I can certainly fix it for that reason. And sometimes if I know that they've got these abfractive lesions, I need to figure out what the cause of that is. But I don't necessarily need to rush to do treatment. I need to figure out cause, and then I need to listen to the patient. Now, if the patient comes from an office and then they're like, well, you got to get that covered, that's something that you've got to take care of, then I'd say, well, here's the thing. When we treat these, we can certainly cover it up, but it doesn't necessarily, you don't necessarily need to replace the tooth structure. So it just depends on what the patient wants.
Last question. I know we went over an hour. Thank you for staying for overtime. But the biggest problem that they're thinking about periodontal disease is it related to the heart ticker. When that heart pump stops, you're dead. And periodontal disease associated with heart disease, you see that on a meme every day on social media. Do you think having gum disease really is related to cardiac health problems with your heart? And do you think that to have heart health, to have gum health, is just a generically simple, obvious idea, like anything to be healthy is better? Or do you think it's absolutely causative? Or do you think that we still need more research and time?
I do not think it's causative. I do think that systemic inflammation isn't good for your body. And I think that anything that we can do to adjust the systemic inflammatory load, be it diet, more sleep, less alcohol, and treatment of periodontal disease, then that's all good for you. But I don't know that I can say confidently that periodontal disease will cause heart disease.
And can I ask you a couple more questions, or
Sure,
do you need to go?
Sure.
Albuquerque is the state separating you and me. I'm in Arizona, you're in Texas, Albuquerque's in between. They just legalized recreational marijuana yesterday. And now it's like a lot of states have done this. And now a lot of the smoking, Marlboro smoking people are vaping. Do you think cigarettes was really the worst and vaping and marijuana is probably a little better? Or are you seeing, what is now that everybody can buy legal marijuana? Is that affecting periodontal disease in your practice, or?
You can't buy that legally here, and I've only had a few patients admit to me that they've taken it. So to answer your question, I don't know.
You don't know?
I don't know.
Yeah, it'll be interesting. It's kind of really interesting. There are some of my dentist friends who swear to God that marijuana smoking is worse for your teeth than cigarettes. And I have a lot of dentists who had a lot of their kids in rehab, and they said in the rehab places, it was just as hard to get the kid off of marijuana as it was opiates or any of them,
Wow.
that it's highly addicted and all that kind of stuff. But my gosh, I could talk to you for 40 days and 40 nights. So you recommend that if they're going to get in implants, to get a Straumann kit?
Yeah.
Yeah. And Thomas Straumann did not give you a Starbucks card to say that?
Nope.
Okay. And my gosh, I'm sure all of our listeners' wives will be glad to be updated on chronic periodontal disease and erectile dysfunction. I hope that helps out your love life. But seriously, man, I was so excited when you accepted to come on this show. And thank you so much for all that you do for dentistry. And thank you so much for coming on the show.
Appreciate it, Howard. Best wishes.